We're all here for a really very important topic that affects each and every one of you, and if not now, possibly sometime in your lifetime. And we're talking about depression and physician suicide. Now, the interesting thing about it is that when you entered medical school, when you compare yourself to your cohort in the general population, medical students are actually more psychologically resilient and healthy than the general population in an age-matched study. But there's something that happens through the course of medical school, residency training, fellowship for some of you, and ultimately through practice that changes us. And as you will see that as the presentation goes forward, our suicide rate compared to the general population, our depression rate compared to the general population greatly increases. And Dr. Wagner, who is a professor and chair of psychiatry and actually a national expert in depression and suicide, maybe international might be more appropriate, is going to talk to y'all about the details. But clearly things change, and although we're talking about residents and house staff today, and of course what triggered this particular session is that a few weeks ago we had an internal medicine resident commit suicide. The last time that may have happened at UTMB was about 10 years ago with an anesthesiology resident who was on an outside rotation in Houston and died of an accidental overdose or a suicide overdose. We don't really know. When there's no suicide note, you don't know. So we don't really know how to characterize that. Maybe it was an accident, maybe it was suicide. So potentially we've had 2 suicides with residents within the last 10 years. But this is not just a problem for residents. And as you age and you leave here and you go into practice, actually the suicide rate for physicians starts to climb dramatically after about age 40, much higher than the general population. So the curve continues upward. So yeah, suicide rate might happen as a resident or a fellow, but after age 40, significant dramatic increases. Since I've been at UTMB, there have been 2 faculty that were definite suicide by gunshot, 2 male faculty. So there's been at least 3 of our physicians that I know of, and maybe 4, that have committed suicide. So this is a very, very important area. And as Dr. Wagner will talk about, one of the problems for physicians is this stigma or asking for help. And one fear that many residents in training have is, will this hurt my licensing with the Texas Medical Board, which is notoriously tough for all kinds of reasons. And actually it will not. I interface with the Texas Medical Board on a very regular basis. And unless you are incapacitated from work for depression for over 3 weeks, we do not report it to the Texas Medical Board. So the likelihood of you going and seeking help or counseling or psychiatric help affecting your ultimate licensure is very low. Not impossible, but very low. We have a lot of folks standing to help, and you're going to hear about the resources that psychiatry is going to bring to bear on this problem. And you're also going to hear at the end about our employee assistance program, which is probably one of the best employee assistance programs in the country. I'm going to stop there, though, and turn the talk over to Dr. Karen Wagner, Chief of Department of Psychiatry. Karen?
Well, it's a pleasure to be here talking to all of you and to see all of you here. So the topic will be on depression, suicide, and physicians. So what is the prevalence of depression in the general population? What you can see here is if you look at your age group, 18 to 25, the prevalence of depression is 9%. For those 26 to 49, the prevalence of depression is 7%. So that's the general population. What about the group you are now in, which is the group of physicians? 29%. That's nearly a third of all resident physicians who will either have depression or develop symptoms of depression. So that is a very, very high number. So how do we make a diagnosis of depression? You'll recall probably from your third-year psychiatry clerkship that there are a number of symptoms people have when they develop depression. First is that these symptoms have to have been present for at least 2 weeks. Now, I've seen a number of patients over the years, and I have yet to see anybody who was presented with depression and said, oh, I've had all of these symptoms for 2 weeks. Usually people have had the symptoms for much, much longer. So to make the diagnosis, there needs to be one of two symptoms, either depressed mood or decreased interest in activities or decreased pleasure. Either or, but usually people have both. Now, the problem with making the diagnosis of depression and the problem with recognizing it is that the symptoms of depression do not develop in a cluster overnight. They tend to slowly creep in. So a person starts to notice their mood's getting a little low. Then things don't seem quite as much fun as they had. Then there starts to be a little change in appetite. Then problems sleeping, usually difficulty falling asleep, or waking up in the middle of the night, or waking up early and not being able to fall back asleep. And then starting to feel slowed down, or for some people, very restless. There's a sense of agitation, and for some, anxiety. There's also feeling tired. And then with being tired can come along decreased concentration. And that decreased concentration is problematic for people to get their work done. And then starts coming in those symptoms of feeling worthless, feeling not as good as colleagues, feeling that your skills aren't as well developed as others. And when those feelings of worthlessness, guilt over not doing everything the way you had hoped you would, that can then start to move on to suicidal thinking, which can be things like, maybe I shouldn't be around, maybe the world would be better without me, no one would even notice if I wasn't gone, then on to intent, well, maybe it's time to end things, and then on to a plan. So those are the symptoms and often the evolution of depression. And what you've got, and you can look at those later in your handout, this is the patient health questionnaire, and it is a screening instrument for depression. And if you look at it, you can see that there are 9 depression symptoms, all of the ones that I've just described: feeling down, low interest, sleep, appetite, energy, feeling bad, suicidal thoughts. And then the ratings are from a 0 to a 3. So obviously, if there are 9 items and 3 is the highest score, the maximum score on the patient health questionnaire screening instrument is 27. What's the cutoff? When is it time to start worrying a little bit? That is a score of 10 or more. 10 is the start of potential moderate depression. And usually people that are depressed start to get a lot of 2s, and then when it gets severe, nearly every day, usually starts several days, then more days, then nearly every day, then that's really concerned that major depression has developed. What is the course of depression? Is it something we can say, well, you know, depression, just let it go, it will go away? The mean episode of depression is 6 to 7 months. And with a mean, that means there are certainly months longer than that for some individuals. So untreated depression can take up an entire year of training, internship year, residency year. And that has significant consequences for overall functioning. The other thing to note is that the recurrence rate is 50%. So if there is anyone that has had an episode of depression, either in childhood, in adolescence, before, during medical school, there is a 50% chance that it will come back. So it's important to note if any of the symptoms, especially low mood, decreased interest, start creeping in, that the depression could be returning. So what is the impact of depression? And this was a survey of depressed residents. And those that were depressed, the findings were that nearly half of them had difficulty fulfilling their medical and professional responsibilities. And they had decreased clinical work productivity. And if you look at this, 80% decreased satisfaction with their work. So work is something that a resident does all the time. And having the productivity go down, the satisfaction go down, causes distress. And for some, that leads to substance abuse. And in this case, 16% of those surveyed were abusing substances. With the problems in work productivity, satisfaction, comes stress. And you can see here nearly all of the residents that were depressed and not doing well in their work felt stressed. 95% had lower quality of their leisure time and difficulty relaxing. And what happens is that you get into a cycle of not doing well at work, raising stress. Stress then raises the inability to do work well because the person can't function because they're stressed all the time, and you get this vicious cycle that can be difficult to get out of. And that then can lead to feelings of suicide. And look at this. This is a number of studies have reported these findings, that 23 to 53% of residents at some point have had thoughts of suicide. That is nearly, so a quarter to 50%. And it could be ranging from, I wish I was dead, don't want to be around, or maybe I will kill myself. That is a strikingly high number. That is 4 times, 5 times, 6 times the general population in terms of suicidal thinking. So it's a serious problem for resident physicians, in addition to physicians in general. What are the suicide rates among physicians? There are 300 to 400 physicians' deaths annually, which means that nearly or more every day a physician commits suicide. And importantly, the gender ratio is equal. If you recall from what you probably learned in psychiatry, is that men are more likely to die by suicide than women. But how is it for physicians that it's equal men, women? What happens is that women who are physicians that make suicide attempts know how to do it in a lethal fashion. Because women, when they attempt suicide, are much more likely to do it by overdose, whereas men are much more likely to use means like hanging or shooting themselves. So women physicians know how much of a medicine or over-the-counter to take to kill themselves. And that now has made it an equal field, gender-wise, with regard to deaths by suicide. So if we look at it overall, compared to the general population, how do physicians compare with regard to suicide? Males are 1.4 times more likely than the general population to commit suicide. Female physicians, 2.3 times the general population of females to commit suicide. So this is an extraordinarily serious problem for physicians. So what are the risk factors for suicide? These are the major risk factors that you would find within the general population. First, depression, having a mood disorder. It is most likely depression, could be bipolar disorder, and anxiety disorders make the problem worse. But depression, the leading mood disorder for suicide-related deaths, paired with substance abuse, using alcohol or drugs. And the problem is that when people are feeling depressed, they often look for something to feel better. And alcohol can sometimes, in the short term, make people feel better, or at least they think they feel better, or using substances to relieve the depression and perhaps associated anxiety. Relationship problems can be a trigger for suicide. And then life stressors, things like financial problems, legal problems, work problems. But these are the risk factors that are in the general population. You are now a member of the general population, but a subset in it, which is the group of physicians. Are there risk factors more related to physicians? Yes. 2. One is a mental health disorder, and it's typically depression, and the other is work problems. So that pairing for physicians, depression and having difficulties at work, are 2 of the major risk factors for suicide. And they, again, fuel each other. Depressed, don't do well in work. Don't do well at work, feel depressed. Do worse at work, feel depressed. And you can see how it goes around, and each exacerbates the other. Now, interestingly, in these group of physicians that committed suicide, there were toxicology reports. Look what was found on toxicology report. Barbiturates, benzodiazepines, not antidepressants. So people were not being treated for depression, but we can imagine that there was self-medication involved here. So how is that? Why is it that physicians who are depressed and have suicidal thinking are not receiving antidepressants. We get to the issue of stigma. And this was a survey of over 1,200 physicians who were asked about depression. And the majority of them had stigmatizing views of depression. More than 2/3 of physicians said that depression in themselves was a sign of personal weakness. I mean, what kind of thinking is this? All of these physicians have been to medical school, know about the biology and the neurobiology of illnesses, of which depression is one, and to hold a view that it is personal weakness, that is factually incorrect. And having that kind of view then leads to not receiving care. And for these physicians that had this view, the barriers that they said to seeking help were things like letting their colleagues down by not being available if they needed to take a little bit of time, or not working as hard if their mood was too low at that moment. Confidentiality, half of them were concerned about confidentiality, and then others were concerned about their career progression. So with all of that then, how are residents getting treatment for depression? And this was a survey of depressed residents asking those that were depressed, that had moderate to severe depression, what kind of treatment were they getting? And look at this. Only roughly a quarter of them were receiving any treatment for an illness that is moderate to severe. For those few that were getting beyond standard treatment, what they chose were 2% were treating themselves, which we don't recommend, monitoring someone's own health, but having someone else do it. And then 6%, they got antidepressants from some provider, but there was no consultation. They just got the antidepressants. And again, that is a very low standard of care. And then 3% got antidepressants from another resident. So not getting treatment is a problem for resident physicians. When treatment is so straightforward for depression. Two things: antidepressant medication and therapy. Therapy can be helpful in a number of ways. And the kind of therapy is not going back to your childhood and trying to figure out what went awry. The therapy really is about, what are you thinking? You know, a cognitive approach. If you have negative thoughts that you're doing terribly, that you'll never do well in the future, that nothing can change anything, that certainly makes people depressed. And then learning coping skills, how to deal with challenging situations, problem solving, resilience, ways to foster wellness. All of those things are components of therapy. So, recognizing depression, and this is really the most important point of this presentation, is the recognition of depression in yourself if you think you have some of the symptoms, what to do, seek treatment. The other is that if you have a colleague who you think may have depression, then to talk to them and encourage them to get treatment. And this is something that people tend not to do. That if someone is down, They don't seem to be doing their job that well. People don't say anything. But yet, if your colleague had symptoms of, say, a horrific cold, look flu-like, they are sneezing, they are coughing, they may look like they're febrile, and you were by them, you'd say something. You'd say anything. You might say, are you feeling well? Or you're not feeling well? You're taking anything? Have you seen anybody? Or you'd say something. It might be as simple as, don't stand near me, don't breathe by me. But you would say something. But somehow, when someone is depressed, down, not doing well, people say nothing. And that strategy backfires for some. And why it backfires is that the person that is depressed, for some people, if it is not acknowledged by others, it confirms to them that nobody cares, that they're not important enough for anybody to have even noticed how depressed they are, which then leads to and confirms their view, why be around? So it can be extremely helpful to your colleagues to encourage treatment. And if you are worried and they say no, and you are worried about their safety, then please discuss this with your chief resident and or the training director so that the person can be directed towards care that may be very helpful to them, if not life-saving. So if you need any contacts within the Department of Psychiatry, if anybody needs to be treated, feels they need to be treated or evaluated for depression or other mental health conditions, we have offices in the Webster Clinic and in the Primary Care Pavilion. Our outpatient director, Dr. Wolf, his telephone number is there. He will, if you call him, arrange directly for an appointment without needing to go through the scheduling staff. And you can also call me. My telephone number is there, and I similarly will take care of it for you. So I hope this has been helpful to you in terms of recognizing depression, importance of treatment for either yourself or talking to your colleagues if there are concerns about having depressed mood. So I want to thank you very much for your attention.
Thank you, Dr. Wagner, for a wonderful talk. In addition to the Department of Psychiatry and their significant resources available to help residents with depression, we have another separate area where you can go, and we're going to have Carol Kerr from Employee Assistance Program come and talk to us about what they have to offer and how their system works.
Hi, I'm Carol Kerr, and I'm from the Employee Assistance Program at UTMB. What we do at Employee Assistance is we do individual, family, and couple counseling. We also see children. We'll see anybody that's a UTMB employee or anyone that lives in their home for free. This is a benefit from UTMB if you're unaware. A lot of people are unaware, and we try to get the news out. There are 3 of us there that are all counselors with tremendous amount of experience. Janet Capps, Deborah Galushin, and myself are certified by various state boards in Texas. I've been in private practice for over 20 years. Our stance in our department is to be compassionate and to care about you as a person. Confidentiality is all important to us. I know from experience that confidentiality at UTMB can be promised often and not given, and we are different. We are proud of our stand on confidentiality and our history with it. We have a reputation for not giving information regardless of who wants it. We take it very seriously. Exclusions for confidentiality are one, if information is subpoenaed by a court of law or a judge, or if someone is suicidal or homicidal and we can't talk them out of it. Or the third one is if there's a release of information signed by the client with specific persons identified and specific information identified in that release of information to be given. Our records are electronic and only able to be accessed by EAP. They are not mixed with in any way the recording system or the records at UTMB. Our location, if you're unaware, is in Rebecca Sealy, room 2.812. We're across the street from Arlen's front door, if you know where that's located. And then once you're in our building at Rebecca Sealy, we're across the hallway from UTMB's post office. We have an emergency hotline that's 24/7 for emergency calls after hours, so you will always be able to reach us. How to schedule an appointment is simple. You call. It's that simple. I like to really emphasize that when to call is always. If you have any doubt, should I call or shouldn't I call, just please remember that I said when to call is always. I know that you would prefer if somebody had an ingrown toenail or a hangnail that they came to see you prior to having a gangrenous leg. Depression is cumulative, as you have heard. We would much rather see you for you to come in and have a chat and say, I'm not really sure what's wrong. I just wanted to come in and talk to somebody who's objective. We love those kinds of people and we welcome them. We talk about anything that's bothering you. It doesn't have to be work. It can be home. So know that there are no off-limits conversations with us. Our philosophy is that we view people who use our services as proactive, intelligent professionals who understand self-care is paramount to being able to provide excellent care to our patients or to UTMB. We do not see people as weak who use our services, but rather courageous and willing to do what it takes to stay in top shape to take care of themselves and their patients. Are there any questions about EAP or our services?
I'll ask one because probably no one else will. So I'm in charge of all the residency training programs at UTMB, and there's a resident seeing you, and I want to know what's going on with them. What will you tell me?
I will tell you that without a release of information, I'm unable to even let you know if that person utilizes our services, much less give you any information.
Okay. You all heard that?
We hold to that. If we hold to anything in our department, we hold to that. And we have, as I said earlier, a history and a reputation for doing so.
Thank you very much. But before we close, I just want to add a couple more points. Suicide is certainly the most terrible outcome. It's maybe the tip of the iceberg. And sitting under that is depression, which Dr. Wagner has talked so eloquently about. But even underneath that, an even bigger problem than physician depression is physician burnout, which can lead to depression, which can lead to suicide. But physician burnout is maybe 50% of physicians go through burnout at one time or another in their career. We're going to be embarking at UTMB on a really strong resident wellness endeavor to try and prevent burnout, because it occurs in physicians in practice, but it occurs in physicians in training as well. So this is just the beginning of working on these issues. We're going to push more prevention to try and prevent you from getting to the burnout, depression, certainly suicide stage. But if you find yourself there, there are many avenues of help, both with EAP and with the Department of Psychiatry. And certainly you can always call our office and we'll do whatever we can to help you. Are there any questions? Thank you all for your attention. We appreciate it.
UTMB Health, working together to work wonders.